complications of acute posterior urethritis. Prostatitis. Any inflammation of the prostate, short of abscess, adds scarcely any symptoms to those of the urethritis. Mild prostatitis, like mild posterior urethritis, may give no sign of its presence, while a more intense prostatitis, accompanying posterior urethritis, does not alter the clinical picture already described. The involvement of the prostate may or may not be distinguishable by rectal touch. Prostatic abscess. In drawing an arbitrary division between acute prostatitis and prostatic abscess, it is wiser to include with the latter all cases of acute prostatitis of sufficient severity to cause symptoms. This for two reasons. All such cases do represent retention of pus within the prostate ducts, and any one of them may progress to unmistakable abscess formation. To attempt to draw the line between the prostate, in which macroscopic suppuration, abscess, has already occurred, and that in which it only threatens, is impracticable. Symptoms. The symptoms of prostatic abscess follow one of three types as follows. The local symptoms are accentuated. To the pain and frequency of urination due to posterior urethritis is added a constant dull or throbbing ache inside the pelvis, which may or may not radiate to the urethra, the testicles, the thighs, the hypogastrium, or the loin. If the prostate is much enlarged, defecation is apt to be both painful and difficult. Fever, often severe and ushered in by a chill, is added to the afebrile urethral inflammation. But fever is no criterion of the extent or progress of the prostatic involvement. Absence of fever is often noted in extensive prostatic suppuration. Retention of urine is a marked feature in many cases. Partial retention escapes observation, but acute complete retention requiring relief by the catheter may occur. I have relieved by operation gonorrheal abscess in both lobes of the prostate, the only symptom of which was acute retention of urine, preceded by no dysuria and accompanied by no fever. Yet in some instances, dysuria, fever, and retention occur simultaneously. Physical signs. The suppurating prostate is always enlarged, usually sensitive. The whole of one or both lobes is involved. The diagnosis should be made long before either boggy softening or fluctuation shows that the whole of a lobe has been transformed into an abscess cavity. Course. The process may terminate by resolution, by rupture into the periprostatic tissue, causing ischiorectal abscess, or into the urethra, or the adherent rectum, or by passing on to chronic prostatitis. Alexander studied 68 cases of gonorrheal prostatic abscess. Of these, 31 appeared during the first gonorrhea, 37 during relapses, 35 caused retention of urine, 22 had burst into the perineum, 16, the ischiorectal fossa, 5, the rectum, 1. The abscess was complicated by urethral stricture 9 times. If the pus burrows forward into the perineum, it may occasion considerable mischief, burrowing along toward the corpus cavernosum, or even laying it bare. It has been known to go through the obturator foramen to low, and even to follow the connective tissue plane about the spermatic cord, and to point in the inguinal canal, or to get into the space of Retzius, to appear at the umbilicus, to pass by the sciatic notch, guion. All very rare, but still possible culminations of neglected periprostatic suppuration. Seminal vesiculitis. Acute seminal vesiculitis, like acute prostatitis, usually gives no sign of its presence. If suppuration occurs in the vesicle, the symptoms are those of prostatic suppuration. But a finger in the rectum discloses a tense, sausage-like tumor in the region of the inflamed vesicle. It usually terminates in resolution, but may rupture into the ischiorectal fossa, the rectum, or the peritoneum. Vesiculitis does not occur without prostatitis. It is impossible to differentiate inflammation of the ampulla of the vas from vesiculitis. Epididymitis, see Chapter 59. Cystitis. The familiar gonorrheal trigonitis already described implies some inflammation of the rest of the bladder, but this is not a clinical feature of gonorrhea. Pyelonephritis. This is an extremely rare complication of gonorrhea. It is best described in connection with other types of pyelonephritis. Peritonitis. Pelvic peritonitis is as rare a complication of gonorrhea in the male as it is common in the female. Batty has collected 30 cases. Thomas reports 2 more. The inflammation is due to vesiculitis or deferentitis. Its symptoms are the classic ones of pelvic peritonitis.